Please welcome Steve Scully back to the stage, joined by our panel of experts, Dana P. Goldman, Professor of Public Policy, Pharmacy, and Economics at the University of Southern California and founding director of the USC Schaeffer Institute for Public Policy and Government Service, Dr. Jennifer Ellis, cardiac surgeon and co-chair of the Health and Public Policy Committee of the Association of Black Cardiologists, and Daneen Sekoni, Vice President of Policy and Advocacy at Cancer Support Community.
What a great panel. Let me begin. I have to begin with the obvious. Is that a prerequisite for an USC
absolutely.
dean to wear the colors and the sneakers?
These are my USC kicks. So.
Well, thank you.
I'm representing.
Thank you very much for being with us. Let me just follow up on all that we've talked about this morning, because one thing is clear. When it comes to drug pricing, Professor Goldman, it is not one size fits all. How do we navigate that so we keep prices low, but also make it accessible and spur the innovation that we need?
Yeah, you've hit on a fundamental challenge, and it is very important to understand that there are dramatic differences for how developers are going to respond. Representative Peters comes from a district, as he said, which a lot of the companies are small. They're investigating things like gene therapies. There may be very small patient populations who are affected by those. And one of the things about the IRA, and of course we all know that the details matter tremendously, it kind of says to people who develop drugs for these ultra-rare diseases, orphan designations, that if you make too much money, if you find other ways to use your drug, you're suddenly going to be subject to negotiation, and we're going to claw back some of your profits from you. So think of that from the perspective of a developer. They say, maybe I want to focus on very rare things and not try to expand the people who are accessible. And that's not good for patients. Now think about the other side of the distribution. Think about, for example, medications to treat obesity. I mean, this has been a remarkable development. It may be one of the most important public health interventions that we have discovered in the last 30 years, and probably could have health effects, if you believe our models and others, that would be similar to the impact of getting people to stop smoking. And yet we are going to tell people who are innovating there that there's the potential, and we don't know yet what the prices will be, that if you develop something so profitable that, again, we are going to claw back. So I do worry about the possibility that ultimately, and we do need to take the long term, it will be, while patients may see a lot of benefits at the counter today, long term, there will be access to treatment will be hindered.
Let me follow up on that. And Daneen Sekoni, I know this is one of your areas of expertise. So to that point, how do you maintain the costs but maximize innovation and creativity and research?
So I think one way you can do that, a couple ways you can do that, from a patient perspective. I always believe it's important, when developing drugs or having these conversations, that patient input is at the beginning of the conversation, and that what matters to patients are a part of these decisions. And what I mean by that is, by including patients in these conversations and understanding what matters to them and what their preferences are, their experiences, you'll know that a patient might be willing to pay a little bit more for a drug that may improve their quality of life, as opposed to another drug that maybe doesn't, or they may be willing to pay a little bit more for a drug that lessens side effects, and that's an area that's very important for consideration as well. I think another area you have to be really careful about is utilization management with respect to cost. And that's one area where we can see that inappropriate uses of utilization management can actually increase cost to the system. We think about step therapy as one approach, that fail first approach, that does not allow that patient to receive that medication that the physician initially wanted, that can cause downstream costs to the patient, to the payer, and to the system. And so that's another area that I think we need to think about really carefully, is how utilization management is being implemented. And lastly, with respect to innovation, there are a couple of bills that we think really address some of those unintended consequences that can support innovation. And it was talked about a little bit, the pill penalty, or the small molecule drugs versus biologics. Cancer Support Community, we support the EPIC Act for the very reason that we know that there are more cancer drugs that are being approved that are small molecule drugs, and we also know that in a lot of ways it can mitigate some of those disparities and inequities that individuals may experience versus an infusion or a biologic. So we want to encourage and incentivize manufacturers to continue investing in that space, and we don't want to discourage innovation for small molecule drugs. We also support the Orphan Cures Act for that very reason. We don't want to disincentivize or discourage innovation. You know, at Cancer Support Community, I always say we have the privilege to serve patients, caregivers, and survivors that are impacted by cancer by meeting them where they are, offering psychosocial support. And what I hear from caregivers and patients, what really resonates with me, particularly in the rare cancer space, is rare disease innovation is so important in a couple of ways. One, when you're told you have a rare cancer, at one point the medication may stop working and you need to have access to something else that works. And secondly, we're individuals, and how we may respond is very individualized and different. And so there needs to be a robust array of medications that are out there and accessible. And so some of those disincentives that we talked about with respect to the Orphan Drug Act and EPIC Act, I think, you know, those are tweaks to the IRA that could really go a long way to preserve research and development.
There's a lot there to unpack. Thank you for that. But Dr. Ellis, let me just take one aspect of it when it comes to the public policy aspect, because we heard from a Democratic and Republican member of Congress, Democrats praising the IRA, Republicans concerned about the unintended consequences of the IRA. So what are your thoughts about that? Are there unintended consequences when it comes to drugs and healthcare and prices through this legislation?
Well, absolutely. There are always unintended consequences because we just don't have enough vision to know how things are going to lay out. But I do want to push back a little bit on some of these orphan drugs. I'm going to say something that's a little bit unpopular probably. The number one killer in the United States is cardiovascular disease. You are more likely to die of cardiac disease or cardiovascular disease than HIV, cancer, accidents, gun violence combined. Everyone in here is more likely to die of heart disease than something else. If you have survived breast cancer, or if you've had breast cancer, you're more likely to die from heart disease than from breast cancer. So when we're talking about some of the consequences, these unintended consequences, one of the things that we were talking about, the Walmart drug price of $4 for a pill, well, that was an inconvenient pill. So like this, there was a beta blocker that was $4, but you had to take it 4 times a day. And if you're not compliant already, so one of the things when people come to my office, I would say, bring your pills. And you would look, and you know, it's a 30-day supply, and there are 8 pills in there. So you know that they missed 12, you know, they missed 8 weeks worth of dosage. So when you're looking at some of these talks of unintended consequences, yes, it was definitely cheaper in the long term because the long-acting pill cost $75. For a 30-day supply, the short-acting was $4 for a month. So which one is going, you know, which one are we going to try to get to the patient? And then if you look at an underserved or less served population, where it is less trusting of your physician, less trusting of healthcare, and then you're trying to change medications around and you're making adjustments. One of the frustrations, especially in the African American community, is if a patient has a side effect, so you're talking about willing to pay more, they have a side effect. More often than not, they do not come to the doctor to say they have a side effect. So one of the things I would have to say for a statin, if it bothers you, do not just stop it. Come and tell us. We will give you a different one. There are about 30 different kinds. We will find one that won't bother you. And patients will be like, oh, I didn't know that was an option. Instead, they will just stop taking it and they won't tell anybody.
Is that just human nature?
That is, it's human nature, but it also has to do with privilege and comfort. If you are afraid to have not afraid, but if you are disinclined to confront or question your physician, and if there is socioeconomic reasons why you are especially not going to have those conversations, if you are in a very busy clinic versus a concierge medication set or concierge medicine service, you are less likely to say, why are you doing this? And this is one of the things that sometimes when you're teaching students, you have to make sure that they're aware of, because they just say something and they don't understand the impact that they can have. And especially on, like, if you talk to my grandma, if you gave her a pill, she wasn't going to question it.
You talk about obesity. What should the role of CMS be when it comes to obesity drugs?
Yeah, I think when I first got started in this field, I remember going, I was working at the Rand Corporation. I was a health economist, and this was back, I don't want to tell you when, it was so long ago, but early 90s. And I went in and gave a presentation to CMS. And at that time, they didn't even cover drugs. I mean, it is rather remarkable that it took the United States until 2004 to pass something that would cover prescription drugs. And I went in and I thought I had done some brilliant analysis where I showed them that if they actually had covered antihypertensive medications, they could save, at that time, $50 billion a year, and in addition, reduce health disparities. And they said to us, yeah, but we don't cover that. And so, and they kicked me out of the room, and I haven't been invited back since, just so you know. So this is as close as I get. And so the point is that I think, when something like anti-obesity, and I served on the CBO's panel of health advisors for many years, and nothing upsets people who work on federal budgets more than if people live longer, because that costs them money in Social Security land. And so the discussion that you hear has nothing to do with what is best for population health. And so now coming back, you asked me about anti-obesity medications. When we discovered antihypertensives, everyone at the time was saying, look, just diet and exercise. Why do we need these medications? Well, it turned out now it would be malpractice not to use antihypertensive medicines. I think
because it's preventative.
Exactly. And our modeling has shown that it could save Medicare $250 billion because of reduced hospitalizations, all the sequelae that come from obesity. We're finding linkages with cancer and the like. And the fact of the matter is we have to figure out a pricing strategy. And the pricing strategy, unfortunately, is not the one in the IRA. The pricing strategy, in my view, should be one where, look, these drugs are much more valuable if you have diabetes and are at very high risk. We should pay you more commensurate with value. And in fact, I find it ironic, we talk about Medicare pricing, but we haven't gotten prices right in this debate because, when we talked about Hep C drugs, it was price per pill. That's not the price people care about. What we care about is the price for health outcomes. And that means tying prices to value. And I'm very worried that implementation of the IRA is going to be about, we just want the biggest discount off list price. And it's not going to be about how do we encourage valuable medication into the marketplace and how do we discourage innovation that doesn't do any good.
So let me follow up on Daneen. And we heard from Congressman Peters. I thought his analogy was terrific, that if you have a leaky roof, do you spend $10,000 to fix it, or do you let it go and then have $30,000 in damage? How do we rethink when it comes to drug prices, especially when it comes to preventative care for heart disease, for obesity in our system today, because the folks over there aren't always doing that?
So, I will always say it goes back to the patient. I think how we rethink drug prices is it goes back to when we develop clinical trials. We develop clinical trials with evaluations around endpoints that matter to the patient with respect to what do they want to see as a result of a treatment or medication geared towards their cancer. And I think that will help determine the efficacy and the value when you put the patient at the center. You're providing prescription, you're providing treatment alternatives and options that meet what they need, that meet their quality of life. Are they still able to work at the end? Are they able to have more energy? Do they have less nausea? Because we know overall survivability is important, but as people are living longer with cancer, we're understanding that there may be other situations or challenges that may arise. And I think that's what's missing, quite frankly, is just at the baseline, at the beginning, at the start of it. And the clinical trials have to be more diverse, quite frankly, as well, when it comes to understanding how patient populations may respond to a medication. We know that certain populations may respond differently, and there's an opportunity there to be more diverse, and I'm heartened by what I saw the FDA release yesterday, to be more intentional in modernizing how we develop our clinical trials, to bring diverse patient populations, diverse voices, and understanding what value looks like at the beginning. And I think that can really help go a long way in addressing drug prices.
But Dr. Ellis, I see you nodding your head as we go through this process. What are your biggest concerns? What are the biggest speed bumps along the way that we should know about?
Well, a major concern, first off, the studies are absolutely one of the things I used to say. However much you differ from being 35 years old, white male, 5'10", and 150 pounds, that's how much the drug will be off for you. Because that was the population that was being tested. No women, especially no pregnant women, no minorities. I mean, it was really that person.
To his point, one size doesn't fit all.
Correct, and when I was in the lab, I mean, we could cure cancer easily in the rat because we made basically genetic clones, and so you give cancer to that rat, and then you have a lot of time to work on it. But so access, accessibility, availability, trust. I mean, these are the things that we just need to work on over and over and over and over again. One of the problems with the studies, if your population doesn't trust you, they're not going to join the study. When I worked briefly in the Bronx, we were the largest single provider of organs for transplant in the United States because of our violence, because it was penetrating violence. And so, when the brain dies, the rest of the body is still available. And in that population, I know of not one organ that went to our population. Mm-hmm. So we would have some families that would not donate because they say, we don't feel that we're part of this process. And so these are more than speed bumps. These are brick walls. If we had something that, talking about preventative disease, I mean, if you prevent obesity and high blood pressure, you don't have to treat the stroke. If you decrease the amount of cancer, if you do some pre-treatment, I mean, not pre-treatments, but, screening. I mean, right now, how many people here over 45 have had their colonoscopy? How many women have had their mammograms? How many of the guys know their PSAs? I mean, these are things that we can just do. And if you're talking cheap, that's cheap.
But there is a real disparity, and this is your area of expertise, Professor, when it comes to those with private health insurance, employer health insurance, and those requiring public health. How do you deal with that disparity?
I think, the irony of this discussion, we're focusing on prevention. So, I came up with a solution that I thought could reduce the risk of cancer, Alzheimer's, cardiovascular disease, and a few other conditions. It was called Going for a Walk. And, it turns out that's really good for you. And, and then I also suggested coin-operated elevators. This would get people taking more steps, and we know that's good for people. But the interesting
Now you are aging yourself, because there are coin-operated telephones.
Exactly. Yeah, actually, no one has coins, I have to admit. The point is, we don't incent, but I don't get any intellectual property for figuring out how to get people to say, and so we underinvest in the preventive side, and then we overinvest in the treatment side. And the irony is, if you develop a drug that mimics the effects of exercise, you do get patent protection. And I actually think we're going in the wrong direction because, we've got all this digital health and we've got all these other tools that we're trying to use. And are we providing people who come up with innovative solutions? And if we really want to save money in healthcare, the way to save money is to keep people out of the hospital. If you can figure out how to do that, we should be rewarding that. And if you look at Medicare generally, that's what drugs do when they work best. They keep people out of the hospital. And we are negotiating those prices. At the same time, we are not solving these preventive health care issues that will drive disparities and costs.
So you go for a walk daily?
Yeah, I do with my dog, yes.
There you go.
There's my solution.
But
And if you want my dog, he's yours.
for either one of you, though, again, it goes back to the issue of striking that balance, of making sure that we don't stifle the innovation that we have in this country, have that ability to create these new drugs, orphan drugs, and maintaining the costs of them.
So, yeah, I did want to just piggyback 1 second on what he said about prevention, because I think they made a really good point about prevention, and then I'll answer your question. Sure. Because I do think if you can find it earlier and treat it, the outcomes are better. And so one example in the cancer space, when we think about early detection, for example, we know that there's an opportunity with the MCED Medicare Coverage Screening Act, an opportunity, to do through one single blood draw to see if there's a cancer signal for many. Right now we have about 5 cover screenings. And we know that there are a lot of disparities, right, with respect to access to those screenings, as he mentioned. And so that's an opportunity to kind of, like I say, like equalize the playing field with respect to all populations being able, and this would be more of a Medicare focus initially, to get access to those type of screenings to see if they do have a signal, they can have additional testing, and if there is, they can catch it early. Earlier treatment, early detection can lead to better health outcomes. So I did want to share that. In the cancer space, when we talk about innovation and striking that balance, so I wasn't ignoring what you're saying. It's a delicate balance, and it's really important. But what I say, I will always go back to, we don't want to disincentivize or discourage manufacturers from trying to identify other opportunities to treat individuals or find other conditions for which their treatment might work. And so what I go back to is what I always say. I think the way to work is it's a coordinated approach. It's not just a one-step approach. I think it requires, again, working with the patients, understanding, what really matters to them, because what we don't want is that downstream effect of, if they're disincentivized to do R&D into particular areas, the prevalence of that condition or that disease, like cancer, for example, may increase, may exacerbate, and lead to higher mortality. And we don't want that. And so while this may not be an easy answer, or a popular answer, I'll always go back to, I'd rather work with the manufacturers and coming up with solutions to preserve innovation. And again, I say that starts with keeping the patient, at the center of the conversation. Because when you keep the patient at the center of the conversation and you understand what matters to the patient, how you look at value and how you look at outcomes are very different. Clinical benefit, economic benefit, well-being also, has a really big part in all this as well. So I always will return it back to bringing the patient into the conversation to ensure that they have a robust array of medications and options.
You want to follow up, and then I have a question for Dr. Ellis, but go ahead, Professor.
Yeah, it's related to two things they said, which is, so a lot of people have, and you asked a question earlier about Europe and what we can learn from that. Think about what we've done in HIV prevention, because, now we have, and there's been a lot of distrust. I did my early work in HIV, and there's a tremendous amount of distrust, but now you can prevent HIV in high-risk populations with a shot or a pill once every month or once every 6 months, rather than, HIV treatment, which at the time when we first discovered it was 15 pills that had to be titrated daily and had to be linked to how much cholesterol was in your meal, and we saw huge disparities. And now we can treat HIV in Africa, 1 pill a day, and we can prevent it.
And that's just in the span of about 20 years, right?
Mm-hmm. Yeah, exactly. And it's a remarkable, and that's the time frame we have to be looking at this. But my concern is, if you go to a European regulator and you say to them, look, here's a treatment, it's 15 pills a day, and the only thing I've done is I made it once every 6 months. the way regulators look at value right now, and this gets to the patient's perspective, they say there's no difference and just give me the cheapest one. And usually the cheapest one is, and what happens is you end up with these disparities. And so when we think about patient perspective on value, we have to take into account all these issues that both of my colleagues are talking about here, which is convenience, accessibility, and trust, and adherence. So anyway, that.
You wanted to follow up?
I did. Just, talking about, we have to do both. If you have a chance, you should look at Lyndon Johnson's last speech. He was having such tremendous chest pain that he was putting in so many nitroglycerins that they're actually falling out of his mouth. Mm-hmm. And that was the only treatment we had. So
1973.
And it's a tremendous speech, and his hair was long and curly. He looked good, other than the heart pain.
And he was young. He was only in his mid-60s.
Yes.
He looked a lot older, but he was relatively young.
And now with cholesterol medication, beta blockers, calcium channel blockers, we have this whole array. So there will always be the need for the acute treatments. But we want more people to delay that as long as possible.
We may have a question from the audience, but I want to follow up on something, Dr. Ellis, because we've been talking about the drug pricing issue, but let's talk about the political side of the issue, because as you well know, Congress is broken. There's very little incentive to cross the aisle and work across the aisle. The good news is this is one of those issues that is bipartisan. What are your thoughts about the public policy role in all of this, and Medicare in particular when it comes to drug prices and trying to control drug prices?
The best thing that happens for drug prices and to control this whole issue is that every one of us will be using it. It's not something that I will be doing for me because I'm going to need this, but you're not going to. Even we're talking about orphan drugs or these other issues, there's always going to be somebody. It won't even be 6 degrees of separation. It will be 3 degrees of separation for anything that you can think of. For pancreatic cancer, for colon cancer, for Alzheimer's, for renal disease, for liver disease, for hypercholesterolemia. Mm-hmm. There will always be something. And so that's going to be our best tool to get everybody on the same page to move this forward.
So to that point, if we were to sit here 10 years from now, what will we be talking about?
I think what I would like for us to be talking about is that the first iteration of the IRA, and I'm calling it iteration, brought everybody together, brought the stakeholders together to have start having some real meaningful, tough conversations about how we can continue to make drugs affordable, but also accessible at the same time, and bringing together diverse perspectives, but really centering that conversation around the patient. And that it may have been tough. There may have been some negotiations and some points of contention, but what that did was it really helped to bring everybody on the same page and to start being forward thinking about what can we do collectively to support the sustainability to quality medicines for all people who need them.
I'm going to give each of you a minute in a moment for a final thought, final word, but we have a question or two from the audience. Where is that?
Back here.
Yeah.
Hi. We have one from Diane Pajula from the American Psychological Association. She asks, how will the 2025 changes to Medicare drug costs for beneficiaries impact Part D plans coverage and formularies?
Do you want to take that one, Professor?
Yeah, I think there are two things. Plans are more at risk for very expensive medications, and so we're going to see more formulary restrictions. If we end up with rebate reform, which you also discussed on a...
So what does that mean?
Rebate reform. What it means is that 30% of what we pay for drug costs right now go to people who do nothing on the innovative side. It's 3 companies, and so it's hard to follow the money because some of it goes into Switzerland and elsewhere. But basically, people extracting from the distribution chain about 35%. So we think when we buy insulin at the pharmacy that it's all going to the manufacturers. In fact, it goes to companies like Express Scripts and the like. That is also a bipartisan issue, and they want to get rid of those rebates. If they get rid of those rebates, what are these companies going to do to answer the audience question, in order to still make that profit, they're going to restrict access even further. So my concern is that the future for us under a very stringent IRA is restricted access for older Americans in terms of treatment.
Another question, thank you.
We have one from Ronald Taylor. Many providers advertise openly that they will take Medicare. However, when one calls for an appointment, they say that this payment option is not available. How can this be mitigated?
Dr. Ellis, are you familiar with that?
Yes, and it's a little bit sleazy on the doc's part. So the medical boards are starting to look into that. And so what they'll say sometimes is, we accept all insurances, but they actually don't. What they do is they have the patient pay fully, and then they will do all the paperwork, and whatever the insurance company pays to the patient goes directly to the patient. So if it's a $200 bill and the insurance company will pay $35, well, the doc doesn't have to go try to get the $165 from the patient. The doc gets $200 from the patient, and the patient then gets a $35 check from the insurance company. So the cure for that, which is not going to happen in the United States, would be universal health, better signage, better communication, and repercussions for the docs who say those kind of things. And one of the things you can do is then compel them to take it. You said you're taking Medicare. You have to take it, and you'll have to take that amount of reimbursement. And then you'll be surprised just how quickly that website will change.
Thank you all for being with us, and I want to give you a moment with a final thought, but this has been a terrific panel. You've added so much to the conversation. So as we think differently about drug prices, Daneen Sekoni, we'll begin with you. Same question to all three of you. How should we think differently?
We should think differently. I like what Dana said earlier. I think one way we can think differently about drug pricing, about healthcare in general, is focusing more on prevention, thinking differently, including those social drivers of health that impact, looking at the person, being more person-centered, thinking more holistically, and how we can, on the front end, as Dr. Ellis said, keep people healthy. So if they do need, the medication, we know that the lifestyle changes would have been such that it was more sustainable to keep that person healthy. So I say we can think about drug pricing differently by, continuing to be patient-focused, patient-first, and bringing in those social drivers of health that we know have an impact.
And take a walk. Dr. Ellis.
I think we need to think about this, that we all have a dog in this fight. So yes, it's great if we can cap the price of insulin and the $2,000 for the cap for the seniors. But we also have to understand that we all, through our taxpayer dollars, through our other choices, we all have a dog in this fight, and that we also, as consumers, need to be part of this decision making. As you were saying, it might be worth paying a premium not to take a pill 4 times a day, not to have the nausea, not to have these other issues. But then it also might be, I don't mind, if this pill is a little bit larger, or if I have to take 2 pills instead of 1, and that'll save the system $50, $100, 50%. We need to be part of that discussion, and we need to be making some of those practical, cogent decisions.
We began with you. We will conclude with you. You get the final word, Professor.
Thank you. I love that. How did we get here? We got here because we spend a lot in the U.S. and we don't think we have very good outcomes. And spending is price times quantity. And it is really easy for regulators to legislate on price. They set prices in Medicare. They want to set prices for drugs. But I actually think the real savings will come from reducing quantity. And as I said, it's reducing how often people are hospitalized and reducing the need to use expensive things that do little good, so that we can preserve the monies to pay for the rare stuff that people need when they are catastrophically affected.
Thank you all so much. A marvelous conversation. Thank you for being with us. And we'll turn back. Joe, final word.
That concludes our program for today. I just want to thank all of our excellent panelists. I'd like to thank Steve Scully for moderating today. I'd like to thank the Alliance for Aging Research for sponsoring us today. And on behalf of the Alliance and the Hill, I'd like to thank everyone for coming in the room and those who joined us online. If you missed any part of this or want to watch it again, this will all be posted on the Hill at thehill.com. We hope to see you all again soon. Thank you very much.